we are now live, and you can go ahead and get going.
Okay, I just want to welcome everybody to our virtual Lunch and Learn Margaritas and Mammos, and thank you guys all for being here today. I'm going to let our panel introduce themselves, but just a few quick reminders that if you are going to participate in the Cancun raffle or win $2,000, you need to buy your tickets right now and have them purchased by 12:40, because winner will be automatically announced at 12:50. So please be sure to do that, and you can go to codyregionalhealth.org and under events find this event, and that's where the tickets can be purchased. So thank you all.
Woohoo! Cancun or $2,000 cash. Okay.
All right.
So we received a few questions from our community, so we're going to go ahead and get started. And we're going to have everybody introduce themselves right now. So if we could start with Dr. Cross.
Hi, I'm Dr. Greg Cross. I am one of the radiologists at Cody Regional Health.
Hi, I'm Thomas Reed. I'm the medical oncologist here at the Bighorn Basin Cancer Center.
I am Cindy Glazier, and I am a nurse. I manage the Wyoming Cancer Resource Services program for the Bighorn Basin.
And I'm Dr. Bryce Lord, radiation oncologist at the Bighorn Basin Cancer Center.
Awesome. Thank you, everyone. So we have a few different categories here, and the first one is screening. So first one is, should I get screened for breast cancer even during COVID?
Yes.
Okay, everyone said yes on that. So yes, get screened even during our pandemic. All right, second one, I'm also going to stick here with screening, is should I plan my mammogram around the COVID vaccine? Who would like to take that one? Dr. Cross.
So the official word to keep things simple is 6 weeks. So plan your mammogram no sooner than 6 weeks after 1 or 2 of the initial vaccines or the booster.
Okay, 6 weeks. Alrighty. So let's go ahead and move into a different category, breast cancer risk. Who wants to take this one? Who gets breast cancer? Dr. Reed.
Yeah,
Okay.
I can start that off. Well, the average risk for breast cancer across the United States is 12%. So 1 in 8 women will develop breast cancer. So that's considered the average risk. There are certain things that you can do to reduce your risk, and that is to have an ideal body weight. There's no question that being overweight, having a high body mass index, and being obese increases your risk of getting breast cancer because your fat cells are making estrogen. So if you can keep your weight down, that would be terrific. But there are other people who are at higher risk for breast cancer, and those are folks who may have a genetic predisposition or a very strong family history of breast cancer.
Great. Thank you, Dr. Reed. Okay, let's go ahead and move on to radiology and imaging. So I just got my mammogram report. What is BI-RADS? Dr. Cross, you want to take that one?
Sure.
Great.
So BI-RADS is an acronym for the way we categorize our reports, the results of the reports. It stands for Breast Imaging Reporting and Database Systems. I think that's correct. I've never said that before out loud, but we've been using it obviously for 20 some years. And so there's numbers attached to it, 1 through 6, 1 being normal, 2 being benign normal, 3 being probable benign, 4 being suspicious for cancer, 5 being highly suspicious, and then 6 being known cancer.
Great. Okay. Thank you, Dr. Cross. I'm going to skip around here just a little bit. I'm going to go under treatment considerations. Does everyone with breast cancer need chemotherapy?
The answer to that is no. And there are certain individuals, the question is, who gets chemotherapy? It's really those women who have a high likelihood of the breast cancer already having escaped the breast at the time of the diagnosis. And there's a number of ways for us to sort that out. And I think a number of women who are listening have probably heard about triple negative breast cancer. That increase increases your risk of having the cancer already having escaped the breast at the time of diagnosis. And there are other considerations as well.
Okay, all right. I'm going to move over here to Dr. Lord and ask this one under treatment considerations too, because I think it's relevant right now. Does everyone with breast cancer need radiation? Can you touch on that a little bit?
I think it's a good question. The predominant treatment that we use for breast cancer is using breast conservation. So if it's possible to get a good cosmetic outcome, breast conservation is offered. And so with that, to improve local control, even if the surgeon got it all out and with a negative margin, we still know that there's a benefit for adding radiation. So they go kind of part and parcel. There are some exceptions to that. As you get older and you move into, let's say, 70 years old and older, if your tumor and the tumor characteristics are favorable, we can discuss the possibility of actually omitting radiation. But right now, the cutoff is basically 70 years old.
Great. Okay. Okay, let's see here. I'm going to move around a little bit. Let's go to breast cancer biology. What does it mean if my breast cancer is invasive or non-invasive? Can you give some examples? Who'd like to take that?
Sure, I can start.
Okay.
So there are different risk factors within the breast that can predispose towards cancer. There are precancerous lesions, one of which was called atypical ductal hyperplasia. That's not cancer, but it increases your likelihood of developing cancer. And those atypical or abnormal cells are within the duct. So a duct is just a channel through which milk is transmitted to the nipple. But the cells that line the duct regenerate over periods of time, so they don't get old, but they regenerate. But there can be changes that predispose towards the cancer. The next step is that those cells could become what's called ductal carcinoma in situ. That's in situ is just Latin for in place where the cancer started within the duct. So DCIS is a cancer, but it's in the duct and it hasn't become invasive. The next step is for an untreated DCIS or ductal carcinoma in situ is that those cancer cells then develop an ability to break through the duct and now become invasive. And when it becomes invasive, then it has the opportunity to spread to lymph nodes and to other parts of the body.
Okay. Which is so important for screening. Let's go back up to screening. When should I begin screenings for breast cancer? Cindy, do you want to address that one?
Sure. Different national organizations have different screening guidelines. Some recommend the age of 40, some recommend the age of 50. So it's best to seek your advice with your primary healthcare provider. If you have any questions about that, you're welcome to reach out to me and we can discuss it on your individual basis if you don't have a primary care provider.
Great. And we will provide Cindy's contact below here as well.
Can I?
Yeah, Dr.
Can I
Cross?
add one more thing to that. So if you have a strong family history, a known relative, first degree relative, typically mother, sister, grandmother, something like that, you should screen 10 years prior to the age that they were diagnosed. So for instance, if a sister was diagnosed or a mother was diagnosed with breast cancer at age 45, you should start screening at age 35.
That's great. Yeah, that's good advice. Thank you.
I'd like to add one more thing. Dr. Cross's professional organization, as we all know, recommends starting at the age of 40. And I think we, as a cancer center here, recommend initiating screening mammography for the average risk woman at the age of 40. Because the risk, approximately 17% of breast cancers will be identified between the ages of 40 and 49.
Okay. Let's go back to breast cancer risks. So can someone talk on the symptoms of breast cancer and what to look for with that? Dr. Lord, would you want to do that one?
Sure, we can start. I mean, I think in medicine you can have many different presentations, and found not by palpation or feeling the breast, but it may be through imaging, your screening mammography. If it becomes more advanced, there may be distortion of the breast, maybe inversion of the nipple, there can be retraction, there can be overlying skin changes. It really depends on the situation. So if I really had to think about most of the cancers that I see, they tend to be asymptomatic, but if left alone, they can certainly become more dramatic and more symptomatic. So that I think it can be a little bit of a mixed bag.
Okay. Do you want to add anything?
Absolutely. But the key thing in this COVID environment, if you feel a breast mass or there's something unusual about your breast, don't wait. We're here to screen you.
Okay.
Well, I should say in that case, it's not screening. It's evaluating for possible breast cancer.
Sure. Okay. All right, let's jump back into genetics. And we kind of touched on this a little bit, but are ovarian and breast cancer related?
They can be. They can be. There is something called hereditary breast, ovarian, pancreas cancer syndrome. And it used to be just breast and ovarian cancer, but now we're adding pancreas, prostate cancer, and melanoma to that as well. So they can be linked by gene mutations in one of two genes and possibly others. You've probably heard about BRCA1 called BRCA1 and then BRCA2 is one way to tie in both ovarian and breast cancer. But not everyone who has ovarian cancer has a mutation, and the same thing with breast cancer. But if you have those mutations, you increase your lifetime risk of breast cancer for those particular mutations up to 70% lifetime risk of developing breast cancer, and for ovarian cancer, anywhere from 11 to 34% lifetime risk. The average risk for breast cancer is 12%, and the average risk for ovarian cancer is about 1.3, 1.4%.
Okay. And we do offer genetic testing over here. So we're going to take a quick intermission here. Someone has something to say?
I'm just jumping back on here because I want you guys to know that we're also going to be raffling off 5 free mammograms, so stay tuned for that as well. We'll announce those at the end of this. And again, just a reminder, jump on, get your raffle tickets before 12:40. So you still have about 20 minutes to do that. And again, thank you all for joining us.
Awesome. And go to codyregionalhealth.org and click on events, and you can see the link there to get your raffle tickets. Okay, let's go back to treatment considerations. Can we talk about the different treatments that we offer here at the Cancer Center? What are those treatments?
We can start with radiation.
Yeah, we can certainly start with radiation. So here for patients who present with breast cancer, typically they're after they've been undergone a workup, including diagnostic mammography, biopsy, and then surgical evaluation and management. They typically will come to see both myself and Dr. Reed. One may be in front of the other, but either way, we're being seen by both specialties. In our facility here, everything we do is external beam radiotherapy, and I think most people will come in expecting a course of 6 weeks of therapy, or I'll just say 5 to 6 weeks of therapy. What we do here is what's called moderate hypofractionation. That's where we actually use a little higher dose per day and condense the treatment down to about 3 weeks. And that's in basically in accordance with other large practices across the country, both academic and other.
So the other thing we offer from the medical oncology standpoint, say we're talking about breast cancer today, we offer chemotherapy if that's appropriate. We offer endocrine therapy, which is basically anti-estrogen therapy, again, if that's appropriate. And in some women, particularly women who have triple negative breast cancer, will add on, particularly in the early stages, will also add on immunotherapy. So we can do all of that here, just like you can at a major medical center. We can provide, as Dr. Ward said, everything you need here for your breast cancer care here in the community, and you don't have to travel. And one thing I think is important for the folks folks listening to know is that we have coordinated care here. It's integrated, and each new cancer patient is actually presented in conference so that the pathologist joins in, the radiologist joins in, medical oncology, radiation oncology, all discuss each individual new cancer so that we all are in agreement on what's the best approach for that patient.
Great.
I should, okay.
Oh yeah, I was gonna say, I'd add one thing about how we do radiation, because I think there are other concerns when people are considering radiation as a whole. And what we do here is we can protect the heart if we're treating a left-sided breast cancer patient using what's called a deep inspiratory breath hold technique. So actually, we separate the heart from the actual breast or chest wall by simply taking a deep breath and holding it. So we have technology that allows us to basically turn the beam on when the breast is separate from the heart and turn off when they go back and breathe regularly. So we have ways to protect the normal tissue maximally in our treatment.
That's great information.
Yeah, I did mention the tumor board who their participants are, and I should also mention that your surgeon participates in the tumor congress. So our local surgeons, our breast surgeons, colorectal surgeons, urologists, and even the GYN oncologist from Billings will participate in the tumor congresses. And with regard to chemotherapy, sometimes we can give chemotherapy before the surgery, not just to shrink the tumor, but also there's important what's called prognostic information in terms of how well the cancer responds to the therapy. So most of the time we give chemotherapy after surgery, but sometimes we give it before.
Great. So I don't just come in here and talk to one doctor. My whole team works with you. That's great. Okay, let's jump back up to breast cancer risk. So how can I lower my risk of breast cancer? You want to take that one, Cindy?
Sure, I'd love to. Dr. Reed mentioned having a healthy weight for your body size, so that's an important topic. Having a healthy diet and exercise are some ones as well. So those three things really apply to all of our health, all chronic health issues that a person can have. So I know we hear them all the time, but they are so important to be mindful of. Do you have any other ones you'd like to add to the list? How to reduce your risk? Limit your alcohol intake?
Well, I think just staying in shape is probably the biggest thing.
For all of us.
Yeah.
Okay.
Yes.
Okay. All right. So I heard radiation can be used for problems besides cancer. Is this true? And if so, what type of treatments do we offer in Cody?
Sure. Basically, these become more non-breast cancer related. Radiation is predominantly used for solid tumors, malignant tumors, but tumors in and of themselves can be benign. So things that we can do here, if I look at from the outside in, there's a condition called a keloid, which is, think of it, a proud scar or prominent scar. Typically, I would work in conjunction with a surgeon to treat immediately postoperatively to be able to reduce scar formation. So it's actually a very short course of radiation, 3 treatments and you're done. So the goal there is just to reduce the scar tissue from forming. Beyond that, I work with orthopedic surgeons for a condition called heterotopic ossification. Basically what that is that typically following trauma or following, let's say, a repeat surgery, a patient may be at risk for calcium basically to accumulate in the muscle around the joint or around this traumatic area. And so if we know it's a planned surgery, what we'll do is we'll actually treat preoperatively immediately before surgery. And what it does is radiation has an anti-inflammatory effect in that setting, and so it decreases the accumulation of calcium in the postoperative setting. So we do that instead of high-dose NSAID or non-steroidal anti-inflammatories to reduce the risk of GI bleeds and things like that. Beyond that, there are other tumors that we can treat specifically in the brain, what are called meningiomas, and typically that follows a surgical resection by neurosurgery, but there may be a case where it's medically or surgically inoperable, and so in those cases we work with our we work with our colleagues to optimize that treatment, but that can also be done here.
That's great. A lot of that goes over my head, but I'm glad you're here doing all of that. Let's go back to some radiology and imaging questions. I've been told that I have dense breasts. Does this increase my risk of breast cancer? What screening is best for someone with dense breasts?
So dense breasts definitely yield a higher risk for that person for developing breast cancer. The best screening tool still is mammography, annual mammography, especially our 3D tomosynthesis is a great improvement in looking at particularly dense breasts. And then after that, there's not a great consensus on how to approach dense breasts. I think it has a lot to do with that person's individual risk factors. Just because you have dense breasts doesn't necessarily mean you need additional screening. If you do, and I think that's a discussion you should have with your doctor, additional screening would include ultrasound and MRI, or MRI. The frequency of that, it's hard to know what to do with that. It's not annual. Some people at high risk might have every other year a screening ultrasound followed by every other year a screening MRI in addition to their annual mammography. It just depends. It's hard to give a blanket kind of guideline for that.
Okay. What does dense necessarily mean? Do I have less fat in my breasts, or what does dense mean?
It's a combination of less fat and more fibroglandular tissue, meaning more of the other tissue. So yes, it's less fat essentially compared to relative to the other types of tissues like ductal tissue and other structural type tissue in the breast.
So is it safe to say if you have small breasts compared to large breasts, are you probably going to be considered more dense?
Not necessarily.
Not necessarily, okay. Just curious. All right. Okay, well, what does a cyst or microcalcification on a mammogram mean? Are they linked to cancer?
Well, so microcalcifications are something we pay a lot of attention to. Most of them are benign, by far. We have computer-assisted technology that picks up almost all calcifications, and it's mostly extra trouble for us because we know most of them are benign. You can see that they're benign, but you have to dismiss them as you go. Particular microcalcifications that we worry about are the smallest ones that we call pleomorphic, meaning multiple irregular shapes rather than just round. So round and the same size, we don't worry about those. We see vascular calcifications that I would consider microcalcifications as well. That's just plain atherosclerosis like you would get in any other blood vessel. Breasts have blood vessels. The ones we worry about are the ones that are tiny, multiple sized, and irregular sized. Also in a ductal pattern, meaning a branching pattern that we know that they're in the ducts, because that's where you get most of your cancers are in the ductal tissue. So that there's a shape, there's a size, number of them, greater than 5, greater than 10, and then in a branching pattern, they become even more suspicious. If they're associated with other findings like a mass, like architectural distortion, we worry even more. That leads to our recommendations to biopsy or maybe just follow them. As far as cysts go, we don't really diagnose cysts on a mammogram. We presume that a lot of the rounded things are cysts that we see year after year after year, and they're small, they don't change size, or they vary in size. They get bigger, they get smaller. So sometimes if you see them for the first time, you have to work them up to find out that they're a cyst. And if they've been ultrasounded before and they're a pure cyst, then you those go year after year after year if they don't increase in size. You might see them increase or decrease slightly, but they can change. And so the last part of that question, can they be associated with cancers? They can. And ultrasound is probably the best way to evaluate that in case there's maybe a solid component associated with a cyst. That is a possibility.
Okay. Thank you, Dr. Cross.
Dr. Cross, can you tell us what a cyst is, just in case people aren't sure?
Well, a cyst is basically, for simple purposes, it's a fluid collection encapsulated by a wall. So we see cysts in virtually every body part. We see a lot of them in the breast.
Okay.
And so by far, majority of cysts are benign. They really don't need any attention once you've worked them up.
And we do offer 3D mammography here at Cody Regional Health, right?
Yes.
Okay. Are you happy with 3D mammography compared to 2D?
It's incredible. We've had it for almost a year and a half. And I can tell you, because we have to keep strict statistics because we get inspected every year for mammography. Our callback rate is much less because of 3D, which is nice for the patient especially, because we were able to distinguish superimposed tissues, indense breasts in particular. The resolution is better. It's like a CAT scan technology for the breast. So you slice through the breast, figuratively, you slice through the breast, and you can see layers 1 millimeter in thickness. And so it allows you to distinguish superimposed tissues. I know one of the questions that always comes up is, why do I have to have such compression on my breast? And they'll use some other word other than compression. And it is painful, but more compression means less dispersion of the X-ray beam, which for us means a better quality image. And it also reduces motion artifact, because you can't move when your breasts are being squished. So there's a lot of physics reasons for having compression. But yes, 3D mammography is wonderful. I think every patient should have 3D instead of 2D from here on.
Great. Well, we just got another question that was submitted by Annalie. Could carrying your cell phone in your bra cause breast cancer? So before we answer that, I'm going to have someone come back on and remind us of something.
This is my last plug. So again, thank you all for being here. If you've not had a chance, I've seen a lot of people's tickets come through the website, so be sure to get the raffle out there. If you decide that you want to just purchase the trip, you can do that for $4,500 on the website. The raffle is still available, so you can still go out there and try to win. Go to codyregionalhealth.org, search events, and log there.
And if I don't want to go to Cancun,
You get $2,000 cash.
I get $2,000 cash.
That's right. So please do that again. Stay with us so that we can share who the winners are of the free Mammos, and we'll keep going with our questions. Thank you all.
Perfect. So who wants to take that question? Because I do it when I go out to the garden or I'm trying to hold my boys. Could I carry my cell phone in my bra? Will it cause breast cancer? Dr. Lord, do you want to take that one?
Sure, no problem. What I would say, so I'll step back a bit because, with radiation therapy, first of all, just to understand it's what we call ionizing radiation, and there are different degrees of how it's used. The type of imaging or the type of radiation that's being used for imaging is of a certain energy. So we'll consider it low energy, so you can actually see an image being generated. With what we do in therapy is we're using a very high energy radiation beam, and so with that, what we're actually doing is it's causing DNA damage. Okay, very specifically, and it's either direct or indirect. Indirect being we split a water molecule that reacts with your DNA, may break it, may bind it. Either way, the outcome is cell damage. Now, when we talk about other types of radiation, so electromagnetic radiation, I think there's a lot of discussion about it, but I would say when we look at the actual science behind it, that we don't really have causality, we don't really have that link, putting those two together. So there's a lot of information on the internet that I think is misguided and also can be very, very misleading for people. I don't think it's harmful, but yet at the same time, I think there's an element of common sense. If anything, that when you put this all together, I can very reasonably say this is something that should not have a link. Breast cancer, cell phone. Otherwise, if you think of the last 20 years, if we just based the uptick in cellular technology and what we use, you would expect to see a correlating increase, and we just don't see that. So I think from that standpoint, I would look into the actual science behind it, and I would simply say that I would not expect a link.
Do you think those little anti-radiation bubbles that you can put on your phones, do those work?
That's a good question. I have not studied that directly, so I would say it's a little bit beyond there. But if I were really thinking about it, it's, if anything, they're an antenna. So it might modify the transmission, but that's a good question. It might depend on the design, but I would defer that to more of an electrical engineer or a signal engineer than anything else.
Awesome. I'm throwing you a couple curveballs just because
Yes.
I can.
Yes.
Here's a good one for breast cancer biology. How often does breast cancer return?
Yeah, that's a good question.
Dr. Reed, you want to take that?
And there's, it really depends on the biology of the cancer. If one has, say, triple negative cancer, those are aggressive cancers, but typically they don't come back in 5 years. If you have another cancer, it's going to be a new cancer, not something that's coming back. Not so much the case for estrogen receptor positive cancers. Again, most of them are cured at 5 years, sometimes up to 10 years. But occasionally, estrogen receptor positive cancers can come back late at 15 and 20 years. Fortunately, that's very uncommon, but it really depends upon the biology of cancer. The key is to identify your cancer early, so you have an early stage, it can be treated. That's when it's more likely to be curable.
Great. I just had another question come in. Why do some women have, I hope I say this right, mastectomy, and some have lumpectomy?
That's
Who would
one,
like- Want to take that, Dr. Lord?
I'll take that. I mean, that's probably a question best served by a surgeon, but as a radiation oncologist, the way I would look at it is think of the volume of the tumor to the volume of the breast. And so when even if you have we'll describe it as a smallish tumor, depending on how much volume of the breast being removed, it may not be cosmetically appealing afterwards. And so that's one of the balance points of when we look at mastectomy versus lumpectomy. It's kind of a basic cosmetic outcome. If there's no way to achieve a reasonable cosmetic outcome, the surgeon's probably going to recommend against breast conservation. Beyond that, I think it's sort of a case-by-case approach. And so there may be people who have high-risk features genetically, BRCA1, BRCA2 mutations, who may decide that they don't want to have increased surveillance. They may want to do these things. But I think as a whole, it comes down to basic volume of tumor versus volume of the breast.
Great. Okay, we just have a couple more questions left before our drawing for our Cancun trip. So let's jump back to genetics. I know we talked a little bit about, when to get screened, but let's also go into when should I get genetic testing if I have breast cancer? So maybe Dr. Reed?
Yeah, that's a good question. So if you have breast cancer, not everybody gets screened genetically. What do we mean by that? It's a blood test to see if you are born with an increased risk of developing so that's what genetic testing is. It's a tube of blood that goes out to a company and they do genetic analysis to see if you have what's called a germline mutation, something that was there from birth and has potential to express itself later in life. So who do we automatically do genetic testing for? Any woman with breast cancer under the age of 50. Any man with breast cancer, again, it's uncommon, less than 1% of breast cancers, but that can happen. Any woman under the age of 60 who has triple negative breast cancer, we screen those individuals. If, however, you don't meet any of those, but you have a strong family history of, say, ovarian cancer, breast cancer, then we would test you if you have breast cancer. But let's suppose you have a strong family history and none of them can be tested and you don't have breast cancer. Well, that's an individual that we would also consider genetic testing for. And I should point out, so that's special just for breast cancer. Everyone who has pancreas cancer, everyone who has ovarian cancer gets the genetic testing. And we do that here. So we can counsel you here about genetic testing, what it means, and we send it off, we get the result back, and then we can talk to you. The thing about genetic testing, so some people ask, well, geez, I've got the breast cancer, what does it matter if I get genetic testing because I've got the cancer? Well, two important aspects of that. Number one is that if you have an abnormality, say BRCA1, and you have breast cancer, what you're increased risk for, pancreas cancer, melanoma, and ovarian cancer. And in men, if you have BRCA2, there's an increased risk of prostate cancer. And so that's your individual risk for other cancers. But then up to third-degree relatives, say great aunts, nieces, and nephews, they could also be at risk and they should be tested. So caring about your extended family, we would want them to be tested as well. And we would counsel you about that.
Great, thank you. Okay, we are gonna just do one more question, and this is for Cindy, I believe. And then Cindy, if you wouldn't mind just kind of sharing a little bit about what you do and how people can get in touch with you. And then I think you have some mammograms you wanna give away.
Sure.
So our last question is, I don't have insurance, can I still get a mammogram?
Most definitely, yes. We are very fortunate that we have great community support. We have a statewide nonprofit organization, Wyoming Breast Cancer Initiative, and their goal is to make sure that every woman who needs screening receives that screening, or woman who desires screening receives that screening. We can go to the website of the state Department of Health, and that is health.wyo.gov/cancer, and you can apply there. And if for some reason you don't qualify for the state program to have your mammogram paid for, then Wyoming Breast Cancer Initiative will step in and do that. In the past, it's very exciting to report that in the past, the cancer program only paid for people that were uninsured, and they now pay for people that are underinsured. So many people have healthcare insurance, but they have very large deductibles. So if you happen to be someone that is insured, meets other criteria, and can't afford to pay your deductible, then perhaps the Wyoming Cancer Program would be a way to get your screenings done as well. So there's lots of great opportunities and venues that we can use to make sure that your screening's paid for. So please reach out to me and we can discuss what's best for you.
Awesome. Okay. What do we want to do next?
Okay, well I have 5 ladies here that have been drawn to win a free mammogram. These were drawn from the people that entered to attend our live event that we're hoping to have in May now that we couldn't have it here in October. And so you all may not need a mammogram or qualify, but I'll be reaching out to you so that we can talk about that. Do you want to give us those 2 winners?
Sure.
And yell them out so we can hear them.
All right. The first one is Amanda Morrison.
Amanda Morrison, congratulations. You just won a free mammogram.
And the second one is, I just want to make sure I say this correct, Kathleen
Wormold?
Yeah, did you say Wormold?
Kathleen Wormold?
I
Yes.
think so.
Woo!
That's what it
Yeah,
looks like.
Yay, Kathleen. Okay, we got 3 more.
Okay, the next one is Juliet Schlacke or Schlake or Schlakey.
Juliet Schlakey. Schlocky.
Okay.
Yay!
Congratulations.
And two more, Amanda Cook.
Amanda
K-C-K,
Cook.
And Janine May.
And Janine Main.
Awesome.
Awesome. Okay, so Cindy will be following up with those 5 ladies. Congratulations, ladies.
Yes, yes.
Awesome. Anything else you want to share about the Wyoming Cancer Resource Services?
You know, if you just have any questions, there's so much information, it can really be a little bit overwhelming to say the least. So please just reach out. No question is silly or stupid. I also have funds available to help with transportation costs. So if you need get your gas costs reimbursed for your screening appointment or for your treatment appointments, then we can facilitate that resource as well, and then also connect you with some national resources that may be of help. So the goal of the Wyoming Cancer Resource Program is to provide patient navigation, to provide education, and then to assist with screening. So if any of those things are something that you or a loved one, family, friend needs, please reach out to me.
Wonderful. Okay. Well, thank you so much, everyone, for being on the panel. We are now going to get ready to have Jennifer up, and she's going to talk about a couple more events that are going on around us in the community and coming up possibly in May. And then we're going to draw for our Cancun trip, or $2,000 cash
Yes.
prize.
So I'm Jen Ball. I'm the director of the Bighorn Basin Cancer Center. Thank you to Ashley, Annalee, Cody Regional Health, and the Bighorn Basin Cancer Center for hosting this great event. Thank you to Dr. Lord, Cindy Glazier, Dr. Reed, and Dr. Cross for their time. We have a couple exciting things coming up. On Friday, October 22nd, Dr. Lord and Dr. Reed are going to be on site here at the Cancer Center, and they're going to be doing a free breast cancer screening event for women in our community. It's going to be from 10 a.m. to 1 p.m. again on Friday, October 22nd. So we'll have you call Cindy Glazier with Cancer Resource Services at 578-2702 to schedule a time. Thank you to Dr. Lord and Dr. Reed for their time for the breast cancer screening event. Again, this is free, and just call with any questions. We also we were sad to cancel our Mammos and Margarita event. We still wanted to get the word out about breast cancer prevention and wellness, but we hope to have our Mammos and Margaritas event on Cinco de Mayo, May 5th, 2022. So please stay tuned for that. We're excited to host that event and more information to come. So again, thank you so much for attending this event, and please know that the Bighorn Basin Cancer Center is here if you have any other questions or comments.
Awesome. Thank you, Jen. Okay. We have 1 minute to go. So how about, I've got one more question. We have all this pink around us and everything, and I know you said men aren't that at risk, but you know, how often do you see men come in with breast cancer? You know, and is that something that we see here locally? Could we address that maybe?
Yeah, I've seen, 30 years experience, probably about 10 men with breast cancers. Again, it's less than 1% of all breast cancers. However, if there's a family history of, say, BRCA1 or BRCA2, then they're at increased risk for getting male breast cancer. Now, from a radiology perspective, have you seen?
I've seen less than that. We've been practicing about the same number of years, but I have not seen 10.
Okay.
Less than 5. So whatever the statistics say, obviously, it's less than 1%. But if somebody feels something, they need to get it checked out, and certainly with the genetic information that we have now that we didn't have before, there's better guidance to who should get checked.
And if I want to get that genetic testing done, it's just a blood test. So I just go through my primary care doctor.
Or you can give the Bighorn Basin Cancer Center a call directly.
Oh, we can reach out to you directly to get
Yes,
genetic
absolutely.
testing. Okay.
Yes, yeah.
Okay. That's good to know.
And of course, we'll keep your primary care physician in the loop, any findings we have.
Great. Okay. Annalie, do we have our winner yet? We're still waiting on the computer.
So just so everybody knows, the winner will actually be automatically notified via email. If you are not the winner, you will also be notified via email. So we're just waiting for that to pop up here in just a little bit on our automated system. So thank you everybody who contributed, and all the donations do go back to our Bighorn Basin Cancer Center. So thank you very, very much.
Okay. Thank you so much, everyone. Be safe and happy October.